for a benefit of weight loss, we need about 5 to 10% weight loss, because this is influencing cardiovascular risk to a major extent. This is not meet the expectations of some of the patients who want to lose 50 kilos of body weight. That's absolutely clear. And if you look at the mean data with all the drugs, in some of them, the treatment effect is really modest, but you must know that in all these patients, we have responder populations and non-responder populations. If you go for a drug which is not approved in Europe, for example, lorcaserin, which is very modest with about 4% placebo-subtracted weight loss, if you go to the responder population, it's more than 10%. So sometimes with some drugs like Orlistat, we know this very well. You can, myself, who studied this many years ago, only 1/3 were really good responders with that drug. And so if you take the others out, you have much better responders then.
Nowadays, we are classifying obese individuals only using the BMI. So what I believe is that we need a new taxonomy of obesity and of classifying obesity, because in this equation that we mentioned that defines energy balance, we have two main components, energy intake and energy expenditure. And it doesn't really mean that all individuals will have the same dysfunctionality. So we may have individuals in which the energy intake component is very important, and that may be the reason why they are not respondents to a specific drug. But in other individuals, the main component may be the energy expenditure, so that they have less brown adipose tissue, or even that their microbiota is different. So the etiology of obesity that we've been really simplifying so far really needs to be tackled. And we are talking always about personalized medicine. In cancer, that's a very important issue. But we haven't done that step in obesity. We really need to go beyond that and really do much more detailed phenotyping of our patients, so that we really identify which are the main components in this person that don't need to be the same for the whole of the obese individuals.
If we do gene-wide association studies for obesity, we get very few hits. But the hits that we do get, 80% of them point to the brain, right? And specifically the hypothalamus, the nucleus tractus solitarius, etc. So what has happened in the past is we thought that it was a psychological disease, which pointed to the brain too, and therefore we tried to use psychological therapies, but that hasn't been as impactful as we wanted to be. Now, if we understand what are the treatments that are effective, we actually point to surgery, and we see that although the surgeons do an operation in the gut, most of the effects are happening in the brain when it comes to behavior of the patient and the way the behaviors are driven. If we look at the medication that we have right now and the two drugs that has been shown, you know, the places where they work are actually receptors that sit in the brain that affect that. So that's why I think, you know, I've put the controversial sentence up there to allow us to shift our thinking and to actually question, you know, what is the organ that is really involved. Now, it doesn't mean 100% of the disease is driven from that, because, of course, obesity is a common pathway of many diseases. And we use the example of endocrinology, where tiredness is the common pathway of most endocrine disease. If you're hypothyroid, you're tired. If you're hyperthyroid, you're tired. If you've got Cushing's disease, you're tired. If you've got Addison's disease, you're tired. But we don't treat the tiredness of Cushing's disease in the same way as we treat the tiredness of hypothyroidism. So as our understanding about the etiology of obesity improves, we'll understand that a significant proportion of obesity is because of the brain disease. And therefore, we can target those patients using a personalized medicine approach.
New drugs are normally adding additional costs to the healthcare system, perhaps with a reduction later on in complications and these things. And we are living in a time where the expectations are that we have an early success with everything. And so in the past, the authorities have been quite reluctant to take up new drugs for obesity and reimburse them. I can tell you in Austria, we had at the beginning, when Orlistat came to the market and Sibutramine, another drug at that time later on, they were only allowed for people with a BMI above 40 and only for 6 months in your life. We know obesity is a chronic disease and should be treated lifelong, so this was useless. The only idea in background was, and I can tell you, that they get below 40, and this was the border above which you were reimbursed the bariatric surgery. So they wanted to get people down, and they succeeded. And then the operations were no more indicated. So, but then they stopped it because they realized that on the long term, this was also not very successful. So in some countries, there was a reimbursement of the older drugs. At the moment, present, I don't know any country where any of the treatments is reimbursed.
And I'm afraid it will not happen so quickly. Though.
But still, we think that it's not our challenge now to discuss about the prices of the treatment, because that the countries have to do with the companies. But we think that obesity treatment is worthwhile to do, because in the long term it will have benefits for the patient, like antihypertensive diabetes treatment and hyperlipidemia treatment.
An interesting approach would be that a given drug could be reimbursed post factum if an individual is treated with that and can show that after 6 months there is indeed weight loss. Because many people try everything. Many people, unfortunately, still believe that it is the drug only that will do all the job without investing in lifestyle intervention. It only works very well if you combine the lifestyle intervention together with a pharmacological approach. And I think for people who are willing to embrace that combined aspect, I personally think that they could be compensated by a reimbursement of the drug. But that is, of course, an individual decision of agencies in every single individual country.